Well, it's an honor to be here. I recommend this for a lot of people, lifelong learning, because it's my own belief that it's the most important thing that you can do as you get older. My belief is that the older you get, the more you should be stimulating your brain. I mean, learning is the best thing that you can do for your brain, and probably the best place your brain can be is in a university. We can put rats in a university, or like a lot of stimulation. Basically, it's stimulation and novelty, learning, you know, having to deal with things. So it's very valuable. And the other corollary with this that you'll hear me mention too is that the older you get, the more you should exercise. So if you're 85, the next year you need to exercise more. Now, most people do that in reverse, and they and like my father, who used to say if he ever felt the need to exercise, he would lie down until it passed. So, but you need to, and I'm also sorry to be following the political bad news with some more medical bad news. That I'm going to talk about dementia, which is, of course, as we get older, a major consideration, and I'm going to talk about some of the newer principles and ideas that have to do with dementia that have been developed. Let me say that when we talk about dementia, which is a progressive, deteriorating brain condition. Now, if you get hit in the head a single time and have a single traumatic brain injury, that's not really dementia. It's a progressive illness. So, and this is the universe of all dementing disorders. And you see the big 65% is the bad one, which is Alzheimer's disease, which is the most progressive and also the most age-related, which is to say, how old you are is the most important question in terms of your chance of having dementia. Okay, now the others, the purple is combinations of vascular dementia and Alzheimer's disease. The yellow, and with this, we don't really understand it entirely, but as our circulatory system ages, there are changes that occur in the brain, and we think this may set up some of the things that happen to the brain as Alzheimer's disease develops. There's also something we call Lewy body disease, which is akin to another neurodegenerative disorder, Parkinson's disease. It's different. Parkinson's affects more of our movement system, but as we've learned, Parkinson's is a lot more complicated than we used to think of it, and it really is a whole brain disorder. And as Parkinson patients get older, they too develop characteristic memory symptoms. So in my office, you know, 65% of the people who come in and say they have memory symptoms and have significant problems, they're going to likely be Alzheimer's disease. Now this is back to the political situation. Here is the forecast for the time ahead, and the orange are the people over 85. So, and what this is saying is because this is an age-related disease, and we are all seeing increased people, the older you get, the more likely are your chances to get it. As we move through this century, what's going to happen is that 85-year-olds will predominate. Now, the problem from my standpoint from 85-year-olds is that, you know, unless they're a guy that's been married several times, their wife may also be, and the husband may also be close to 85. So you have a system that is limited in its ability to fall, and then you get sometimes the bowling pin philosophy of where, you know, the husband's trying to help the wife, then they both fall, and you've got two fractures, which is bad news. Back to the exercise. We'll talk about that later. Fractures, very bad. So the disease was discovered by a German physician, Alois Alzheimer, and he saw it in a 51-year-old female who was paranoid, suspicious. She was delusional about her husband. And he looked in the light microscope and discovered the characteristic signs that we still see today, which are senile plaques, which we'll talk about a little bit, and tangle cells. And he saw them and he said, this is not like the other paranoid disorders. This is a paranoid disorder that's primarily related to deterioration of cognition and memory. So it hasn't been long that we've known about it. And the other issue is because we're living to an older age, we're seeing it more clearly. You know, you don't see it you know, 100 years ago where life expectancy was in the 50s or 60s. You don't get these crazy numbers that we get now in patients like over 85, over 90, where you think close to 50% in patients over 50, over 90 years old have Alzheimer's disease. How can that be right? How can you have a disease that affects almost everybody? Well, one factor is there's a lot having to do with aging. A lot of the things we think speeds the illness are non-specific aging factors. So what are the risk factors? First, poor vascular health. So if you've got diabetes, if you've got other vascular disorders, you're more likely to have this disease. And it has a lot to do, we think, not just with diabetics, but how glucose and insulin is utilized. You may have read recently that inhaling insulin in a study that came out of the University of Washington helped patients with Alzheimer's disease. Inhaling insulin missed, and we think that may be a way of supercharging the brain. Hypertension, because it's another non-specific aging factor that occurs throughout the body. Head injury, not such a great thing, and particularly as you get older. We think that, and there's a lot of work done here by some of the neuropathologists at Vanderbilt that said that if you have a significant head injury, especially later in life, that may begin some of the pathological changes that occur. Now, the people that we worry about are some of the football players who get hit in the head for a living. And of course, we have a concussion center here that's really leading the way. Dr. Solomon, Gary Solomon's one of my colleagues who does that, works with the Predators and all these people, and I have to say now, you can't play him, you know, you can't play him in this big playoff game. This happened several years ago for the hockey team, and he was not real popular, but the recurrent head injuries are very serious. The younger you are, if you fell off the changing table as a child, you're okay. You're still making neurons. You're making, when you're an infant and a small child, you're making millions a second. A second. Every second you're making millions of neurons. As we get old, excuse me, as we get older, that stops, and we don't make many more, although there's some ways we can do it. You don't make many neurons. You pretty much got to do with what you got. So how many neurons do we have? Nerve cells in the brain? About 100 billion, which is why we can't understand things very, very clearly. Low intelligence, what sense does that make? Well, we think it has to do with brain reserve, which is why you're here, which is when you learn facts, when you learn Italian, your brain changes physically, and you have higher brain reserve. Your neurons have more connections, and we think that helps you to protect against neurodegenerative illness. So the more you learn, the more friends you make, the more new moves you learn to make in chess, the better you do. What about TV? The Learning Channel, would that be good for people? The Learning Channel or the Discovery Channel? No. No. Not only is it not good for you, it's bad for you. TV, it's a myth, and we grow up with it, and we love it, and all that stuff. It's bad for you. It increases all-cause mortality, type 2 diabetes, cardiovascular death. These are people who watch TV more than 4 hours a day. So it's bad for you. TV's bad for you. Piano lesson, good. TV, bad. Because a piano lesson, you're working at it. You know, on TV, you're sitting back and opening your mouth and, you know, watching stuff. We also think depression increases. Now, increases your risk for dementia, as well as post-traumatic stress disorder. So not only if you hit your head on something do you get it, but also if you go in and experience bad things, if your brain experiences traumatic, emotional, whatever. We send people to Afghanistan and they undergo horrendous experiences. That too increases your chance of it. So again, we got some non-specific sort of aging factors. What about lifestyle factors that will, and let me say this, and we'll talk some about genes. Genes are not destiny. And if you get to be 70, your lifestyle makes more is more important than your genes. Once you get to 70, your lifestyle is more important than your genes. Sedentary inactivity, bad. That's very bad, as we know. We'll talk some more of that. Smoking, you might as well put a gun to your head. You know, it's so bad. It's like, because of the vascular changes. Forget cancer of the lung. Forget that one. It's the vascular changes that smoking initiates that are so terrible. Shortens the lifespan of men 15 years who smoke a pack a day, and for women about 13 years. You know, we tolerate it, you know, but okay. Heavy drinking, bad. Moderate light drinking may be good. You hesitate to say this because, you know, I don't want to encourage everybody to go out and drinking, but it looks like alcohol may be helpful. And there's a lot of data from some studies, especially some Scandinavian and European studies, that suggested that alcohol was good for degenerative disease. Alcohol good, but you got to do it in moderation. It looks like wine. You may have seen in the news that the guy who was doing a lot of the resveratrol research was making up his data, but that's nothing new in science. Let me tell you, they all make up the data. They're all, you know, I mean, it's obesity, that goes back to the diabetes. Low cognitive stimulation. So instead of a university environment, we could create a TV environment. And again, when people look at, you know, assisted living, nursing homes, and so on, you know, and I've seen them all. You know, the thick curtains and all that stuff. You want a university. I had a Vanderbilt professor. He said he was going to Oberlin. He said because to move to their assisted living, because he said they've got a workshop, a gym, and a library, and that's all you need. Those are the things you need: the workshop, the gym, and the library. Not TV, high-calorie meals, and sitting around not doing anything. So those are the things we think that are problematic. And Western diet. We know what a Western diet is. High-fat dairy, a lot of animal fat, and too much food, which is the major problem with the American diet, is that we eat too much. Calorie restriction, by the way, has a lot of anti-aging effects. Calorie restriction, for a lot of different reasons. We think it may simulate a starvation cycle where in animals the data is quite clear. And you can limit just by cutting it. I recommend about 15% will help you. You don't need as much of that food, and it's the hyper-refined carbohydrates. You know the stuff that's bad for you. The stuff that's good are fruits and vegetables and not a whole lot of meat, not a lot of domesticated meat. My goal in life is to be spokesman for the American Sardine Federation. Because I think sardines are the ideal food. First of all, they're wild fish. They're not domesticated fish. They're wild fish. They're small fish, so they haven't eaten a bunch of other fish where they get a lot of mercury. And they're oily fish. And the fish oil is good for us in the diet. So fish is pretty good. And in fact, if you increase your fish meal, just eat one fish meal, exchange that for a steak or high-fat meal and a week, and that makes a measurable difference in outcome. We talked about, and the head injuries, we mentioned small head size. This is my favorite one. Small head size is a negative. The smaller your head, the higher your problem for dementia. And the reason is that if you have a small head, you don't have little bitty neurons. You got regular neurons, you just don't have as many of them. So you've got a great big head, you got more neurons, and so you have more neuronal reserve. So you have more ability to take up for this. Toxic exposure. Well, you know, we used to think a lot about that with especially heavy metals. They're bad for you, and we thought a lot of aluminum was particularly bad. But the fact is there's a lot of aluminum everywhere. We got a lot of aluminum in the Cumberland River. You know, we drink it a lot of aluminum. And there were studies when we used to think that aluminum was a problem of aluminum miners, and we looked at them, and they were okay, frankly. They did not show an increased incidence of dementia. But other heavy metals tend to be bad. Recurrent depression, I mentioned that before, and that is if you have recurrent depression for reasons that are not entirely clear, it does set you up for increased neurodegenerative illness as you get older, and low intelligence, back to the low intelligence and low education. Those are bad. High intelligence, high education, good. And social isolation. Because as I said, when you make a friend, you've changed your brain. There's a physical change. It's a myth that we have, I think, part of our hubris about ourselves and our brains, is that our brains always stay the same. And that but the fact is, it's the most dynamic and changeable organ in the body. And also that we can always go back. You know, we send these kids to Afghanistan, they come back with, you know, traumatic problems, and we say, oh yeah, we can give them some counseling and we can go back to where they were before. You can't do that any more than if I drop this laptop on the floor, I can go back to 5 minutes ago and everything's working. Okay, now we're going to talk about Alzheimer's disease and new ideas about what goes on. The fact is, when people walk into my office and they have clear-cut memory symptoms, usually the spouse is the one that notices it first. They have probably had this illness for 15 or 20 years. 15 or 20 years. So it has developed before, and that's what we call the preclinical stage, where we think we can measure changes that have occurred in the brain, but they haven't yet produced the symptoms of suddenly they have what I call a malignant memory symptom. It's not forgetting, you know, one of the 10 items on your grocery list, but forgetting that you went to your aunt's funeral 2 days ago, you know, that sort of thing. And that begins early, and we think that some of the changes of Alzheimer's disease occur as much as 15, maybe more years. And then it reaches a point of mild cognitive impairment. And that's when patients are forgetful, but they don't have dementia. They're not diagnosed. But it's clear they're forgetful, their memory's not as good. Now here's the problem, is that as we get older, all of our memories tend to decline. And in fact, perceptual motor memory, you know, this kind of stuff, and, you know, video game activity, that's best when you're about 21 or 22. That's why they don't put you guys in fighter planes, you know. But they may make you, fly a commercial plane, because those guys, like Captain Sully, they make good decisions because they were there before they had computers. They said, yeah, I know, I've done this, I've seen this happen before. It's the old medical adage that good judgment comes from experience and experience comes from bad judgment. You know, you make enough mistakes and you learn from. So there's a lot to be said for crystalline intelligence. So mild cognitive impairment then is when clear-cut forgetful symptoms are present. Forgetfulness that's not normal, and then how many of these people progress to Alzheimer's disease? Now, if you follow them for about 10 years, about 80% do. But remember, now we're in a population that each year it's higher. 65, you know, I talked about the 90-year-olds where almost 50% of people have, and we used to think that if you're over 90, you're in the clear. You're okay. You dodged the bullet. No, you didn't dodge the bullet. So it still is an increasing problem as you age, and it just gives you these weird, unbelievable numbers. So the incidence increases with age, and then develops into dementia and we'll talk about what happens. This is looking at the actual brain cell and a protein called amyloid precursor protein. Now what Alois Alzheimer found was there were something called amyloid plaques, and we discovered how the amyloid in the 80s we could clone the amyloid, and we really figured out what exactly it was that he saw. He looked in the microscope and saw these broken down cells, and in their place were these pieces of amyloid. So this is where it came from, a so-called amyloid precursor protein. And what we think happens to cause this is that the yellow piece up here is cut by mistake, and that is we have protein cutters, as you would, that sort of recycle and reutilize proteins in the body. And we have certain secretase enzymes that cut the protein in the right spot that it can be used. Now, we think through some genetic factors, the yellow strip gets cut by mistake. And the yellow strip then becomes the heart of these amyloid deposits. And something we call beta amyloid. And here are the scissors cutting it in the wrong place. It should be cutting it north of this scissor right here. should be cutting it further up so that the amyloid particles are not neurotoxic and insoluble, both of which they are. So this is what happened. And then it forms into these beta amyloid plaques, and that's what we think happens. So it happens at the basic level of protein activity. And so what we have tried to figure out for the last 30 years is how do we stop this process, and what's going on? Why should it happen? So, and that's what we think is the first step toward treating the illness, is altering this deposition of amyloid. Now, amyloid is related to cholesterol. Amyloid is related to cholesterol, so if your cholesterol is low, that's a good thing because you have less amyloid activity. So we think low cholesterol. And remember, we talked too about hypertension. So many of the things that help your heart will also help your brain. So controlling hypertension, lowering cholesterol, increasing activity, all the things you'd go to cardiac rehab for. You know, the problem is the heart is a lot easier to figure out. All it does is pump, you know. That's all it does. But you know, it's pretty complicated. It's got electrical circuits and all kind of stuff, but all it does is pump. It's its only job, pump, pump. And we've got to like think and feel and remember and do a lot. The brain is a lot more complicated, and it's much more responsive to other kinds of evolution. I mean, the brain changes, has a lot of redundancy. You think of people who've had strokes or people who are blind, who then develop other parts of their brain so that hearing is more acute and more effective. You ever get on an elevator and you say, how in the world does a blind person ever figure out what those little bumps are? You know, well, the brain changes and becomes more, recruits certain other areas. So we're back to the preclinical stage. The amyloid accumulates, all that yellow stuff accumulates, and we could measure it. So what we're looking for is what the we got cardiology envy, because you know, they got the cholesterol, and you go in the office and they measure cholesterol and say, here, you need a medicine to help your cholesterol. That's what we're looking for. Now, cholesterol does help amyloid, but it's not the whole picture. So what we're trying to do is, at some point, to figure out what would we do if we see these people early in the stage. What would you do if we're in this preclinical stage? And then as time goes on, you get the nerve cells begin to become injured and damaged. And there's evidence in this of subtle cognitive change. Faster decline, a little faster decline than you might notice. A little faster decline. So, by the way, don't worry about recognizing people. We did lots of work on facial recognition. That's what most people, you know, you go back to your college reunion, you say, oh, that's old Joe, you know, I guess. And then, or worse than that, it's 5 minutes later, that was Joe. And you know, that was, that's that slowing of, and most people, people used to think, well, you know, older people just don't function as well. They need more time. Processing speed slows. That's one of the things that happens. And if you give seniors more time to process, they actually function quite well, better than we thought. So slower processing speed. The other test that I do ask people is when you have to do two things at one time. And cooking is one of the best things. I say, well, when's the last time you cooked for 6 people, Mrs. Smith? Cooking for 6 people, because then you're doing 3 things at once and you're kind of on a time schedule. It's kind of tough. Probably one of the most sensitive measures of early cognitive change. Early is your ability to manage your finances. Your ability, and there's a attorney who's a researcher in Birmingham who's done some very interesting work, and he has the scale. The hardest thing for the managing finances was figuring out what was a fraudulent, what was crooked. That was one of the hardest things. But even managing a bank book and investments, that is a really important thing. Now, the good part is, if you do that, it's good for your brain. So those of you who have an appointed spouse who manages it, you join too, because you want to push your brain in terms of understanding it. And it is an early sign of some of the cognitive impairment. So this is the mild cognitive impairment. We passed. Remember, now the first part was that preclinical stuff that happened 15 years before they ever had symptoms. Now they're at mild cognitive impairment. Now they are forgetful, clearly forgetful. They may have some issues at work going on. They're still good drivers. That goes fairly late. Still good drivers. So it's about 15% of elderly have this mild cognitive impairment. It tends to be a mixed group, though, a heterogeneous group. So you can get it if you have bad diabetes. You can get it if you've had a couple of strokes. You can get it for a lot of different reasons. There was an Aricept study, and here's the problem we got into. There was a study that said, well, look, if we find these people early, we can give them the medicine that's good for Alzheimer's disease, and it'll help them. They got better. They won't go as fast. They'll do better. It didn't work. It didn't work. One of the problems was that the way we do these studies, you have to compare them to the placebo group, and then the patients who are on medication for for real Alzheimer's disease, they do better than the placebo group. Well, the placebo group didn't get worse the way we expected to. Yes, question. Over 65. Over 65. Okay, that goes. It has a lot to do with how old I am. So it gets old. I'm going to change it. Next year, I'm going to change that to over 75. So what happened was they got a little better for but then after 2 years, the improvement was lost. It was gone. It was gone. So the idea that we can start this medicine, or we can find out who the people are, give them some of the medicine, and these are cholinergic drugs that improve memory. They'd improve memory. Go downstairs and find these college students, it would improve their memory. Because, by the way, if you had a drug to give to a horse to make it run faster, who would you give it to? A racehorse or an old house horse sitting out there in the pasture somewhere? No, you give it to the racehorse because they're going faster. And so those are the people, they don't know it, but it helps their memory. These cholinergic drugs that we use for Alzheimer's disease, it helps their memory. So, so we identify, the other thing we identify these is amnestic, meaning memory, primarily memory, and then non-memory. So the memory part, we feel, those are the ones we worry about progressing to Alzheimer's disease. If they have early cognitive impairment, they have mild cognitive impairment, but the core of their problem is one of memory. It's not, for example, praxis, how do you button a button, or how you do some physical, you're dexterous in your physical activities, or you you have social judgment errors, like you say shit in church or something like so believe me, come to my office some afternoon and we'll do it. People go to funerals and say stuff, so that's kind of frontal lobe, but it's not memory. It was not memory. It had nothing to do with memory. It has to do with judgment and saying the wrong things. We have a test for letter generation, what we call letter fluency. So we give them a letter. So how many words can you think of that? And guess what letter we pick? Start with the letter F, because we're looking for that disinhibition. So I won't go there. I've got a little judgment. Okay. Let's skip that. So what happens is the amyloid causes the brain cells not to work, and with time, they die. The brain cells die. And so that was the third thing that Alzheimer's saw, in addition to the amyloid plaques and the neurofibrillary tangles, which were all products of the neurons dying, was that the brains got smaller. They shrunk because the neurons died and they got smaller. Now, if we follow people with Alzheimer's disease through the course of their illness, their brain really does get smaller. But if you go to see your doctor, and it makes no difference. That is, if there's some atrophy, that doesn't mean anything. It only means something in terms of the progression of symptoms. So if we wanted to take CAT scans or MRIs repetitively, we could do it and it would make sense. But a single MRI and CT is not really very helpful. The amyloid rises early in the disease, and of course we don't entirely understand it. It rises early in the disease, but later in the course of the disease it doesn't increase as much, something that would confuse us, because we thought if the amyloid is the cause of the illness, as the illness progresses, it ought to increase. Okay, let's talk about genes. This is the scary part for everybody, but we used to think that the illness was different for people that were very young. And if you see it in some 40, remember Alzheimer's first case was 51. And there are cases at 48, in the 40s that you see. And these are different genetically than the people after 60, we think. But clinically, and in terms of looking at their brains, they're the same. We used to divide them, but it doesn't, pathologically, we can't make any sense of the division. So there are a few genes. Amyloid precursor gene, that's on chromosome 21. It's very unusual, it's a rare gene that you have increased amyloid precursor protein, and it produces more of that protein that made all those little yellow bars. Now, one interesting thing is Down syndrome, trisomy 21, those people seem to have, and they're also on the 21st chromosome, also Down syndrome have a high rate, very high rate of developing Alzheimer's disease at premature aging. And we think it goes back to that 21st chromosome where the amyloid, the so-called amyloid precursor protein, lives. Then there are two other genes having to do with some of those secretase enzymes, those cutting enzymes, and one is called presenilin 1 and presenilin 2. Now this top group is less than 2.5% of patients. Very rare. But if you're one of those 2.5%, you see them in their families. A lot of the so-called Mendelian dominant pattern, so that they're close to autosomal dominant. That means, you know, it's a 50% chance you're going to get it. Remember what I said, though. Remember, genes are not destiny. After you get to be 70, your lifestyle matters more than your genes. And then after 60 rather, there's another gene called apolipoprotein E. And that's another one that seems to be a risk gene. It's related to cardiac function, and it was developed by cardiologists. But there are three forms of this gene, E2, 3, and 4. And if you get E2, that's a good thing, and it seems to be protective for dementia. E3 is neutral, E4 is the bad gene. And if you have two of the fours, it's worse. These increase the chance of having substantially of having Alzheimer's disease, but it's not. There are people that are 4/4 who have those genes that are not. It's not specific. They don't necessarily have the illness, but it increases your chance of having it. Now, we'll talk about genes a little later. Hold it. Yeah, there are a couple of others that are important, and some of these were discovered here at Vanderbilt. Clusterin, and this is a complement reacting gene. These are, and a lot of the genes we're finding now have to do with inflammation and inflammatory process and insulin regulation. So these are the things that we're trying to work on now. Now, my goal is to make, is to push back the age that patients show symptoms from 85. Let's push it back 5 years. If we can't solve the genetic problems, which we don't know enough about to solve it, if we can't solve that, then what we can do is we can change a lot of function so that you don't show the symptoms till you're older, 5 years old. If we don't do that, we're going to have big problems, because we're going to have lots of people we can't really take care of. So many with our aging population. By the way, it's going to be a worldwide problem, and the countries that will have the biggest difficulty are those that have had birth control, birth control, who've limited birth. And so you look at places like Japan and China, where they are limiting the number of births. So what's going to happen is they're going to have a larger proportion of older people that the younger people support. But there won't be as many younger people. And we're going to have that as well. You know, it's frightening to look at the figures. The number of people who, in 1945, who worked versus those who were retired or disabled is like 45 to 1, and now it's almost 3 to 1. It's terrible. You don't have Americans on disability. I saw this last week. We were talking with some of the medical students. Americans on disability, 49 million. And those figures are not those are not in any of the unemployment figures. 49 million Americans disabled, and about 20% of the population. So, okay, imaging, not that helpful. It's mostly we have to use looking at amyloid, and there are a couple of compounds that we use. This is one that's just recently developed to help identify the amyloid. The problem we got is, if we find it, what do you do about it? You know, we don't have drugs that are good enough at this point to help us treat the problem. So what are we you know, we're isolating them? I mean, I'll tell you a couple things we can do, but we'll, you know, stop watching TV. But you should stop watching TV anyway. You know, what I tell patients, first of all, don't ever watch TV in the daytime, please. There's a study that they looked at people who watch daytime television, and their intelligence like slanted down. And I would say this too, it's bad for 4-year-olds, it's bad for 14-year-olds, it's bad for 34-year-olds, it's bad for 84-year-olds. All the things that make it a problem. So we talked about eat less, yes.
Are there any populations in the world that don't have it anywhere?
That don't have TV?
No.
No,
I'm
no.
sure there's that.
No, they don't.
Don't have all.
No, they don't. No, there is no population. There's a lot of bogus data out there on all these people and so on in Russia that live to be 120. Well, guess what? Those people were in World War II. They didn't want to fight in the military. They didn't want Stalin to send them to the front, so they handed them their parents' birth certificate. So it has to do. So if you're talking about populations at risk, pick a population where they did a good job of measuring, like the Danish or the Swedish, where they really do check and they've got great birth and death records. But you know, these people from the, you know, the steppes of some, you know, they don't have good birth records, so you can't believe what they say. No, there's no. We think that it's worldwide, and the other problem with this, I've talked to researchers who have said that no, this will happen to everybody. It just depends on what age you are. Maybe that your age is 120 that you get it. That the mutations, the genetic mutations happen. So, yes?
You keep talking about the evils of TV, but once you mention 4 hours, is 1 hour harmful?
No, well,
One brain can run out of TV.
can you watch an hour? Yeah. The data that showed increased type 2 diabetes, heart disease, increased heart disease, and increased all-cause mortality, those people were watching a lot of TV. They were watching, I think, over 4 hours of TV.
Was that because they snack and eat?
Well, we don't know entirely.
Is
We,
it actually something coming from the television, or is it or something?
we don't know.
Maybe
We don't know.
Drink beer and.
Yeah, I mean, do they eat more corn chips? I guess. I mean,
Or maybe they're just sitting.
watching an hour is not going to. It's going to hurt.
Maybe
It's not
the
going to hurt you.
sitting might have to do with
Yeah,
inactivity.
it's probably the sedentary lifestyle. Yes.
I received a good bit of health bulletins, and Dr. Will sent a bulletin stating that in India they have little or no Alzheimer's, and they are accredited to the amount of spices and stuff. like
Curry,
that and so forth.
curcumin. Yes, curcumin. The question is, in India, they have a fairly low incidence of Alzheimer's disease, and that's been reported. But again, you're relying on your quality of your records, and we think that curcumin has an effect on amyloid. That is curry powder. Curry reduces amyloid burden and there's some interesting studies about that. So curry food, not a bad thing. Yes.
But curry is a blend of several spices. Have they
Curcumin. The
isolated-
curcumin is the one that's most helpful. Yes. Yeah.
What's the question?
Well, that's probably what happens a lot. Yeah. When we talk about genes, that's an excellent point. When we talk about genes, a lot of this is activity that happens after you're healthy and an adult. That is, the genes mutate and initiates this whole process. And remember too that the genes if you look at the genes, there are also inhibitor locations and promoter spots on the gene. So you can do certain things that will, we don't understand that entirely, that will actually alter the expression of the gene. So yeah, question.
If a person doesn't show symptoms yet, the preclinical,
Yes,
they wouldn't go and see you.
right.
So how do we ever know when we should start having ourselves tested? Or
Well, testing is a good question. Should everybody be tested? Most people say no, we shouldn't. You should wait till there are important symptoms. I say, take a course. Now, one thing about this course is, I don't think they give tests. right?
No.
Take a course where you have to have a test. And if you make an A, I don't worry about it. I say that, that comes up a lot of times in my practice. Do you want to order neuropsychological testing? Or no, just go down to Nashville Tech and take their computer course. And if you get A, I'm fine. I'm happy with that. If you can make an A on the computer, some course that you can take. And what we'll see, I think, in the future is that we'll wise up and realize that this kind of stuff is really what we need to be doing. And we need to have many more adult education opportunities and activities. The problem, back to the TV, when I walk through my neighborhood with my dog at night, because I get home kind of late, every TV is on. And everybody's inside. When I was a kid, you had to go, my mother made us go outside. You couldn't stay inside. The only reason you could come inside was to go to the bathroom and get back outside. And every other kid in the neighborhood was also outside. So you walk through the neighborhood and you knew all the kids. And now we've got a thing where everybody's inside doing Xbox. These kids, where they're murdering people on the computer and all this business. I mean, is that kind of, I'm a psychiatrist, so that can't be healthy, can it? Okay, so what do we do? What do we do to treat this? Cholinergic system is mostly what we do. And the drugs that are available for Alzheimer's disease are Aricept, Exelon, and Razidine. These are the 3 drugs, and they all stimulate the cholinergic system, activate cholinergic activity by blocking cholinesterase, which is one of the enzymes that chews up the parts of acetylcholine after it's been released. So we have it in common. The other anticholinesterases that you're probably underneath your sink are the insecticides. They're much more powerful because the acetylcholine, in addition to having to do with memory, has to do with muscular function too. The brain uses, it's one of the things that's really terrific, that the body uses these same neurotransmitters for different purposes. Like oxytocin and vasopressin, has a lot to do with water regulation in the kidney, but in the brain, really interesting stuff about maternal bonding, oxytocin and vasopressin. Read about it sometimes. Monogamy, that's another lecture. Monogamy, we got neurotransmitters that have to do with monogamy. I mean, there's some animals that, this is pretty much of a sidebar. Some animals that if you kill their mate, they're finished. That's it. No more mates. That's it. And others that have lots of other mates, and there's a fascinating literature. Read it sometime. Oxytocin and vasopressin with behavior. Okay, we're back to the cholinergic memory system. So the drugs we use are Aricept, Exelon, galantamine. All these drugs are now generic, and so almost everybody should have a chance, and these should be, and you can have some benefit. Now, it doesn't help every patient, but we think that it really probably softens the course of the illness in a lot of cases. The side effects tend to be gastrointestinal nausea, because that's what cholinergic agents do, is they speed the activity of your gut. Now, we know one thing that's bad for you, your memory, and that's anticholinergic drugs. And the more we find out about that, we think that those are bad drugs, and they may do some permanent damage. What are anticholinergic drugs? Benadryl, Bentil, Tylenol PM has Benadryl. That's don't quit taking that if you're over 60. It's just not good for your memory. Other anticholinergics, and lots of anticholinergics, for example, we use for bladder, doctors use it for bladder function, which is a problem. So we've tried to develop safer anticholinergic agents for bladder incontinence, what's euphemistically called overactive bladder, I've said, what's that? Overactive. You're peeing in your pants. So we use lots of drugs, but they are designed to try to protect your brain from the anticholinergic, because cholinergic's good. And then muscarinic receptors can be helpful. And actually, Paul Newhouse, who's a faculty member of ours, just published, it was just last week, that nicotine patches helped your memory. Nicotine patches in a population of people with mild mild cognitive impairment, nicotine patches. So, by the way, smoking, if it wasn't all those tars and stuff that were carcinogenic, wouldn't be so bad. I mean, nicotine itself is pretty good. It also has, smoking has a little bit of an nicotine and antidepressant effect. That's why people have a hard time stopping in addition to the rewarding. So that's another lecture. And then the glutamatergic system, a drug that called Namenda. So most people who actually have Alzheimer's disease at one point will be exposed to those drugs at the top. And we think they are very, very helpful, but they're not. This is not penicillin. Clinically marginal. This was in a review in the Annals of Internal Medicine. I think they're a little better than that, and they're not. I wouldn't call them clinically marginal. I see patients that make really meaningful improvement, but I think that probably is 25 to 40% of cases where you see that, and in some patients it doesn't do a whole lot. And here's a slope. This just shows you that it's not huge. The orange line on the top are patients who are on Aricept. This is some of the early data with Aricept. And the bottom line is the placebo. And basically, there's a substantial, this is a change in mental status questionnaire, and that is their ability to identify, what's the date, start multiplying and that sort of stuff, or adding and subtracting. So it's about a close to a 2-point difference, but that's, if you measure it over time, it can be meaningful. But it's not a penicillin. This is not penicillin, and we're trying to find more better strategies. What are we going to do? Well, this is gamma secretase inhibitors. That's that first scissor. Those two scissors were the gamma and beta secretase enzymes. And so what we're going to try to do is we're going to block these enzymes. The problem is that protein synthesis is kind of important, and so we may be doing a lot of other things that cause problems. The cholinergic agents, they stimulate, they give you a little more cholinergic load, but they don't really have any significant long-term effects, except slowing your heart. Slowing your heart. I talk to guys on the rescue squad, and they say, oh yeah, those are the old people we see who are out all the time. It can slow your heart rate because it's the vagus nerve, and so anticholinergic makes your heart go faster. So you take the Benadryl and your heart might beat faster. Cholinergics can make your heart slow, and so there are a few patients who will pass out from bradycardia, but that's unusual. So we're going to try to figure out some way to block the beta secretase production, or even modulate it, and then we might try to figure out some of the how to stop the neurotoxic effects. Now the other weird thing is vaccination. You could vaccinate for smallpox or measles, but vaccinate for this amyloid plaque. So people have actually tried that, and they can use active antibodies. That is, we introduce the plaque and see if your body will make antibodies to it. It seemed always unlikely to me that it would, but there's some interesting data. And then passive antibody, where they actually produce the antibodies and then infuse the antibodies to amyloid and see what happens. Well, they started this about some years ago, and they used this one compound, but it failed. That study failed, and many of the patients developed an inflammatory response to it and did poorly. So we are still looking at that. And then we talk about passive antibodies, and we've done some of these in my clinic, where we've infused passive antibodies, that is, the antibody to the beta amyloid, and we fuse, and they tend to be safer. This study is not yet out, and in general, the news on most of these drugs, the newer drugs, the drugs that really attack the core of the illness, because the cholinergic agents that we use are pretty much symptomatic. They help memory, but they're not specific to the illness. These are more specific to the illness, but they haven't worked. And most of the news from the Alzheimer meeting so far has not been that encouraging in terms of, and these are different kinds of passive antibodies. The bottom line, they didn't work, but we're still looking at them. We've also used immunoglobulin, which is an it's used for to suppress the immune response. And one of the feelings is that those amyloid plaques may generate an immune response from the body and cause inflammation. So that's been something that that was done, and it's still in progress. You'll see the results of this fairly soon. Yeah.
Is any of these, are any of these things, especially that sinister amyloid protein, is any of that reversible?
Is any of it reversible? Well, we don't know. Is it possible, once you get the amyloid plaques, to reverse it, to reverse the inflammation, to reabsorb it? Now, we think the cholesterol with heart disease, we think a lot of that is reversible in heart disease, for example. We think atherosclerosis can, you know, there's some data on this.
Amyloid protein is so sinister, it almost has a persona of its own. I can just see it now on a comic.
It's bad.
The amyloid protein monster.
Yes, it's scary. Well, we should all be scared. So now, what are some of the other advanced treatments? Nerve growth factor. I met the guy who was a Vanderbilt PhD this morning. I saw him recently. Stanley Cohen, nerve growth factor, which is to try to generate. We're trying to generate nerve. We think nerve growth is a good thing, and he won a Nobel Prize with this. So nerve growth factor is an interesting thing that or what we call brain-derived nerve growth factor, and there are ways that we have of looking at certain drugs and certain activities that increase it. Then there are some other drugs that I won't mention that lower or reduce the injury of amyloid or reduce the clumping of amyloid. The drug that you might, and we mentioned curcumin at the bottom, resveratrol, which is in the red wine, and the other drug that's in your closet is probably non-steroidals. Non-steroidals, which we think help protect against some of the, and we've used lots of alterations on the non-steroidals. And in fact, you know, if you look at the data on the, when the new non-steroidals came out, like Vioxx, the data that they used to show that this drug increased heart disease was Alzheimer's data. They gave it to Alzheimer's patients because we thought, here's a safe non-steroidal, and we'll see if its anti-inflammatory effects have meaningful improvement. Yes?
Is there any data on resveratrol as far as amyloid?
Resveratrol is an yes, there is, and look it up. There's a lot of animal data that you can find on resveratrol, which is this component of red wine. It has a lot of it, but you have to drink a lot of red wine to get the resveratrol. And they sell it at Sam's and at Costco, you know, the resveratrol. But there is, in terms of its effect on amyloid and reducing amyloid damage. Now, we're going to talk about some good things. So I said we're going to not eat as much, and the stuff we eat is going to be stuff your grandmother probably told you to eat, vegetables, fruit. And then the other issue is fitness. And there is emerging a very powerful literature on the value of fitness. I spend most of my day in my office harassing old ladies into working out. Say, you got to get out and walk, you know. And I'm talking 90-year-olds, 95-year-olds, because the older you get, the better, the more powerful the data on the health effects of fitness and activity. The older you get, the more powerful is the data. The other issue is if you look at fitness, you can do absolutely nothing and you're going to make it to 65. You can eat all the wrong foods. You can do, you know, stay on the couch, watch TV all day. You'll still be alive at 65. It's after that that the lines diverge, the people who have fitness activities and those that don't. And of course, then they get to 65, and that's what most people say, well, it doesn't make any difference. You know, it doesn't make, if I work out or not, it doesn't make any difference. That's when the difference really kicks in. Fitness actually reduces brain tissue loss in humans, and high levels of recreational activity lower inflammatory markers. So fitness not only is going to help your brain develop, but fitness it helps inflammation. Now let's look at the diabetes literature, because diabetes, remember, has a lot of correlations to the vascular disease of aging and dementia and all that business. And the two things that help diabetics more than metformin and the initial drugs for type 2 diabetes are fitness, exercise, and diet. exercise and diet, and the kind of exercise. Okay, what should they do? Well, this is what I'll do. I say everybody needs to walk at least a mile a day. Now, let me put it in the form of a week. So you need to put 7 to 10 miles a week. So if you don't walk today, it's raining, Dr. Pete. I've heard every excuse. It's raining, it's too cold. If I go outside in the cold, I'll get wet and I'll become ill. Well, that's wrong, frankly. I mean, if you're outside, you're less prone to infectious disease. It's in the wintertime. It's not because it's cold in the winter. It's because we're all inside and all the viruses circulate. So I've heard all the excuses. 7 to 10 miles a week, and there is a lot of data on that. Now, it needs, sadly, shopping doesn't get it. This kind of walking, has of little or no medical value. But this kind of walking, where you're actually walking in a rhythmic, active form. And in older women, this is great, quadriceps strength was associated with higher executive function. Now, it could be that the people who are fit are also the people that are doing other good things, but I say have strong legs. The other huge benefit of walking for people as you get older, especially for women, is falls. Don't wait till you're 85 to say, I think it's time to get in shape. Because you need to start now. You need to start an active program. And if you don't have time to exercise, skip a meal, preferably supper. That's the best one to skip, because that's where you get, So I think that we need to have a lot, and it doesn't. You don't have to go to the gym and wear leotards and all that business, but you can walk, And in fact, 60, 70 years ago, you would have walked. You would have walked everywhere. Yes.
Stationary bicycle or elliptical machine.
Yeah, it's good, but remember, you got to push yourself. The thing with and I've seen some do the stationary bikes, but you got to push. What you want to do is you want to make more muscle, and the way you make more muscle is you break down muscle. So you injure the muscle, so you do it till it hurts, basically. And that's the problem. The young kids get that. They understand it. So they, till the last time they lift it, and it doesn't have to be a lot of weight, but it's repetitive. The National Institute of Aging has some really nice fitness materials for seniors that are very helpful. So let me show a couple more slides, and I'll get back to the questions. Here's the best one. If you remember one slide, the hippocampus is the part of your brain that has to do with memory, we think, some of the initial phases of memory. In 120, aerobic training over a year increased the size of the anterior hippocampus, leading to improvement in spatial memory. It increased by 2% in the exercise group, and guess what, in the people who didn't exercise? It shrank. And that shows, too, that as you get older, you lose about 1% per year of your muscle mass and your bone mass, about 1% a year. So in 10 years, it's 10%. So when you look down at your legs and say, they look kind of different, they don't kind of, that's that effect of that. So what you've got to do is you've got to be working on some resistance. So not just the walking. Walking's good. The aerobic walking is good. A brisk walk, and there's some data that suggests that that the brisk walk is about as good as a slow run in terms of its fitness benefits. So this is some more exercise stuff. Even if you have dementia, fitness improves because it lowers the cardiovascular risk factors. Yes?
There's been some press lately on a researcher, I believe, with the National Institute for Mental Health, who's looking for what diabetes in the brain looked like.
Yes.
And it looked like, it turned out it was Alzheimer's.
Yes.
And it had to do, one of the risk factors, I don't know if this was cause and result, but I got the impression that it was processed meats.
Yeah. Read the China study. It's a book, the China study about animal protein. Yeah, the point being made is that diabetes in the brain, and in fact it's been expressed that type 1 diabetes is the insulin deficiency. Type 2 diabetes is the so-called adult onset diabetes, where instead of not having enough insulin, we become less sensitive, so we're resistant to the insulin that we have. And we think it's associated with a lot of dietary problems, excessive carbohydrates. And then type 3 diabetes, which is some of these diabetic effects as they have their effect on the brain. And it's a very significant factor. And as okay, what you do is first diet. We talked about the sardines, and those of you who are sardines naive, start with premium sardines, the most expensive one. They don't have the anatomy of the fish in there, and the oh my, this is the spinal cord of the fish, which is a turnoff. Start with premium sardines. The problem is that a lot of the fish have mercury, which is bad. Remember we talked about toxic, and so you need to limit your intake of the predator fish, and those are the shark, and you're eating more shark than you probably know, swordfish, and other kinds of fish that eat other fish, because what happens is that they concentrate the mercury concentrates in the muscle. They eat all the little fish, and then they develop high levels of mercury. There's a famous Minamata Bay calamity in Japan where there was an industrial plant that was spewing mercury into the bay, and then the people in the town, it was a fishing village, they would catch the fish, eat the fish, and then they developed a neurological and cognitive syndrome from mercury poisoning, basically. So you have to watch mercury. You limit your intake of tuna, and so you don't want to eat that all the time. We're looking for healthy sources of fish, and of course most of the fish you buy, 80% probably, is domesticated fish, which is and the problem with that is, where did these fish come from? Most of the fish in North America, pretty good, that are raised here. There are some European salmon farms that that have been some bad reports. I pretty much keep up on it, because I'm always telling people to eat more fish. The wilder the fish, the better. So, all right, questions. I think this is about it. Fitness, cognitive activity, diet, reduction of stress. Yes?
For people who have physical problems that limit their
Yes.
ability to walk, is water exercise?
Yes. Yeah, and you make an excellent point. What if you have physical limitations? You've had arthritic problems and you cannot walk. What else can you do? Water exercise is good. The ellipticals that you mentioned before are also useful. Frankly, the weight bearing of walking is nice, and it has a lot of benefits, caloric benefits, that sometimes you don't get, but water exercise is terrific. It needs to be tough. When you go to your water exercise, you ought to be kind of nervous. Oh no, here I go again. It's like, it's like I go to a spin class and I say, I hope Carla is not here today. I said, don't you ever get to go downhill with them? Yes. The China study, I can't tell you who the author is. Read it. It's a study of looking at the occurrence of heart disease and cancer in Chinese peasants where they had very limited animal protein, low intakes of animal protein. So I'm saying, it's the Western diet. You go down here to Morton's or, Ruth's Chris, that is the Western diet. Not just enough the steak, not enough. And it's a corn-fed beef. Read another of my favorite books by Peyton is called The Omnivore's Dilemma. Did anybody? It's a great book, fabulous. And there's a chapter in there about the life of a beef cow. I'm going another sidebar here. The life of a beef cow. It lives about 16 months, beef cow. And your grandparents your parents, if they were farmers, their cows probably lived 6 years, and they didn't eat corn. That's the problem, is the corn, and then they send them to Kansas City and put them on feedlots and feed them corn, which is one of the problems, we think. Yes?
How about caffeine?
Caffeine looks pretty safe. And in fact, there's some data that suggests that, like, for things like Parkinson's disease, caffeine is pretty good. Let me tell you, I ain't quitting it. I don't care what they say. Caffeine, pretty good. Yes?
I'm going to guess a lot of people here are big readers. Does
Yes.
reading go in the same category as TV?
No, reading's good for you. Reading is good, because you're using your brain, you're using your imagination. And radio is not so bad. I mean, when's the last time you sat around and listened to, the radio with family or friends? It's different. TV, you don't say anything. You stand there and look. Hush, don't say, I'm listening to this, Yes.
Okay, so the question is it the sedentary part of sitting in front of the TV? Because as a therapist, you sit and
Yes.
you talk to clients all day.
Yes.
So you're not being active.
Right.
You are interacting
Yes.
with people, but
Yeah.
you're not being physically active.
Right.
If you're reading, you're sitting
Yes.
and reading.
Yes.
So is it the sedentary or is it the activity?
Sorry.
And-
Yes.
Okay, it has another part. So if you walk 3 miles 4 times a week and you do calisthenics or whatever,
Yeah.
and then you sit more than 4 hours a day.
Stretch. Is sitting bad for you? And is sitting bad for you? And unfortunately, the answer is it probably is kind of bad for you. And so you got to intersperse activity. We need to create active lifestyle. I had a friend that went to China. He said, they went to the parks and people are all worked there together. They're doing Tai Chi. Take a dance class. That's the other key about the fitness. Is it has to be fun, something you enjoy, and you want to make it so when you plan a vacation, next vacation, plan it around fitness activities. So you're going to go somewhere that you might walk or you might bike. Yes.
I think I read an article about there might be some benefit from the peppers, Tabasco and cayenne and jalapenos and all that. Is it true or not?
Peppers, and I don't know. I think I read that. I don't know, to be honest. Are cayenne peppers, good for you in cognitive functioning? I don't know. It's good for pain, yeah. You put it on your elbow, but yes.
Could you comment on the availability nowadays of autopsy material in terms of
Great point.
understanding?
Excellent point. Excellent point. Autopsies. Do we know, because autopsies have gone a little bit out of favor, and do we need to, we have a limited amount of autopsy material, and that is when we look at these brains and really can say what actually happened, what was the problem with this brain. And I usually encourage families of my patients to get autopsy material because it helps us, and we don't exactly know what to do with it all, but we still, I think it's still a very valuable source of information about the illnesses. Yes?
Laying aside animal protein.
Yes.
Just for the purpose of the question, can one consume too much protein even if it's, say, soy or gluten or?
Okay, good question. Can you consume too much protein? There's a really interesting paper just recently looking at people who diet and this protein. Most people, if you look at diabetic diets, it's important to balance it. And I think balancing and eat something that tastes good. I'm not trying to spoil everybody's fun. You can still, but eat a moderate diet and understand that in a lot of restaurants, it's kind of creepy the amount. I was going somewhere and we stopped and got a soft drink, and it was so large that you didn't quite know what to do with it. And you drank a little bit and you pour it out. Soft drinks, by the way, probably bad news too because of the refined carbohydrates. Yes.
I'm curious about the diagnosis. When Dr. Alzheimer's saw these plaques,
Yes.
I was told that for many years, until fairly recently, the only way you could diagnose Alzheimer's
Was autopsy.
posthumously.
Okay. The question is, how do you make the diagnosis now? How do we achieve a diagnosis? Do you have to be dead and on the autopsy table before we can tell who has Alzheimer's and who doesn't? Turns out now that we're pretty much clinically 95% certain that you can make a good clinical diagnosis by, first of all, there are not a lot of illnesses that develop over 10 years like this, that impair multiple areas of cognitive functioning and progress in the way that Alzheimer's disease does. So it's not that tough. And in fact, a lot of family members that I have seen, and I work with a lot of families, will say, I think they're some of the best diagnosticians. They say, yes, my neighbor's got it. They haven't figured it out yet, but they do. But it's the progression of symptoms that develops it, and it develops insidiously, slow start. You don't even know it starts. Gradually, Whereas with vascular disease, for example, you have a stroke and bam, you can't talk and you can't speak. Alzheimer's disease, you may reach the point of having language and aphasia, but it develops very slowly and gradually. There are different patterns, and then sometimes the illness can, affect one side of the brain more than the other.
But you can see it in an image now.
Well, sort of, but the imaging is over. We don't know, the imaging is helpful. The best thing is PET scans right now. But, I've seen PET scans that were wrong. And the PET scan they use, it's a metabolic sort of pathway. It's like if you looked at your car and we could track where the gasoline went in the car. And that's how the PET scan operates. It looks at metabolism. It labels glucose and follows it through the brain, and what areas of the brain are using glucose, what areas are not. And so in Alzheimer's disease, the biparietal impairment, that's kind of classically where it starts. Whereas other illnesses like frontal dementia, it may start here, and in some of the Parkinson's syndromes, you get some posterior symptoms, and that's why they often see things, because you get posterior pathology. Yes?
I have two friends who have definite memory problems and keep telling you the same stories over and over again, don't realize. However, they are excellent bridge players. Now, can it be in certain areas that Alzheimer's hits you and not
Yes.
in others?
The question is, can you have a terrible memory and still be a pretty good bridge player? And the answer is yes, because it's an overlearned in certain kinds of things. Now, they're going to have trouble. Their biggest problem is going to be remembering the cards, but people who really care about stuff, it is amazing. The other area that I have found is I never ask men about football, because football I have found is the brain has a protected area, and that's where football is. And you can ask. I mean, I got people that don't. I mean, they don't know anything, but they know how the Vols did last week. And, they know about the coach, and they know why they did this and that. And it's like, so I give up on that. And I mean, and for women, if they can tell me who the most valuable player of the Super Bowl is, that's it. They're excused from any neuropsychological testing. Yes. Pat Summitt has unfortunately an early form of dementia. I think she's 59. Yeah, so she has a progressive sort of what we would say one of the before 60 types that may be one of the more densely inherited forms of Alzheimer's disease. I don't know anything about her particular case, but I think it's very positive that we reduce some of the stigma, because there's still a lot of shame and stigma associated with this disease of the brain, more so than people who say, yeah, I have cancer of the breast, but you're not embarrassed or ashamed. Whereas with cognitive failings, there's more of a sense of shame, unfortunately. Yes. Yes.
Each day. With that kind of early onset dementia, is that going to help her, or is that just...
It's going to help her. Puzzles help. Puzzles and games help. TV doesn't. And I think we're out of time. Thank you.